So we're going to enter into a group of presentations. First, John Rother is going to lead us off by helping us to understand how healthcare costs have really changed over time. And then we're going to have a panel about how early adversity affects us through our life course and what some prevention methods might look like in order to help to stave off some of those consequences. I have found the clicker, and so this is good to know. Please join me again in welcoming John Rother.
Okay, thank you, Dr. Osborne. And so why are we here? The reason that the National Coalition is doing this nationwide series of discussions and meetings is what I'm going to address right now. And the thesis of my talk, the bottom line is, we're on an unsustainable course. And we need action. We need consensus about direction. And we really need change. And I hope you agree with me. Let me just illustrate the challenge that we face, and then I'll turn it over to our panelists to address some of the substantive issues. So, I mentioned earlier that the National Coalition is made up of a lot of different stakeholder organizations. It's everyone really in healthcare except for the pharmaceutical industry. We have goals for our series of summits across the country. The main thing we're trying to do is lift up success, lift up positive ideas, and articulate a direction for the future of our healthcare system. We are faced with three major challenges. The challenge of demographics, the challenge, as the Commissioner just indicated, the social determinants of health, the things outside of healthcare that are driving the need for care, and the special situation of children. As he said, the lifelong impact of adverse childhood events, and the real challenge facing our entire system is the epidemic of chronic disease and chronic conditions that are increasing in every age group and driving most of the cost of care these days. And we have a system that's not particularly well suited to managing those chronic conditions. So we have, I think this should be pretty well understood. And again, the Commissioner touched on this as well. Certain behaviors that feed into chronic conditions and that end up driving cost of care. And we know that about half of total healthcare costs in any one year are attributable to the sickest 5% of the population, and those people, not 5%, are typically people with multiple chronic conditions. So that's where the money goes, and that's where we need to focus if we're going to get a handle on how to improve the situation. Well, in terms of total cost for our healthcare system, this is not news. We're getting more and more expensive every year. We're way more expensive than any other advanced country. And the increase is outrunning our ability to pay. It's outrunning our economy. It's outrunning inflation. And it's causing all kinds of problems in terms of sucking up the resources that we need to deal with some of the other issues involved in actual health as opposed to health care. So I was a member of a commission at the Institute of Medicine a few years ago that was charged with studying waste in healthcare. And this is a summary of our conclusions. It was a very thorough, very exhaustive study, and it basically found that we spend about 30% of our healthcare dollar on things that do not improve health. But it's not any one thing, it's across the board. And so there's no one simple answer, there's no one simple solution. It involves clinical waste, administrative complexity, certainly pricing, and fraud and abuse. So there's a lot here that we could do to make our healthcare system more functional at less cost. But these are tough. These are tough issues. It's not a silver bullet. It's a lot of different ideas have to work together. Here is a breakdown of where the dollar goes in healthcare today. In the interest of time, I'm not going to go through that, but you can see that most of the money goes to people with multiple chronic conditions, and this is, again, a problem that wasn't the case when Medicare and Medicaid were first enacted in the mid-60s. Then the problem was acute care. Today, it's a whole different situation, and yet we haven't really changed the design and functioning of the programs to deal with people facing chronic disease and chronic conditions. So we know that healthcare costs are a problem. They're a problem in the private sector for employers. Employers have responded by shifting some of those costs to their employees. And as that has taken place, employees are faced with higher and higher premiums, but also higher cost sharing. So here's the data on premium growth. This is scary. It's taking place in a time when healthcare costs in general are considered to be pretty modest in terms of growth, but yet the premiums are growing very fast. And along with the premiums, we have a huge growth in deductibles. Many employers are dealing with the premium pressure by switching to high deductible plans for their employees. And so people may not be used to the fact that now when they need care, they're faced with thousands of dollars in out-of-pocket costs to get access to that care. And of course, that is a serious issue for many, many people. We have seen very rapid growth in deductibles, again, an average of almost $7,500 per family. Many families, particularly modest income families, just don't have that available to them. So this is a crisis of access to care as well as affordability, even for people who have insurance coverage. When we look at the public sector, and going back to the creation of Medicare and Medicaid, we see rapid growth in costs. Some of this is demographic, but a lot of it is per capita cost increases, per patient cost increases as people are consuming more health care per person and more expensive health care per person. So we know that in terms of ability to pay, just the average American household has about $60,000 in income, and yet look at how much of that goes for health care. I don't think most people are aware of this because many of these costs are hidden in their employer compensation and in taxes that we pay. But we are facing a crisis of affordability, and the consequence of this is that the recent wage gains of productivity have been entirely wiped out or offset by increases in the cost of care. So as healthcare gets more expensive, we're not growing our way out of the ability to afford it. So we see more and more people who report that they are having difficulty paying for care and getting access to care, even with health insurance coverage. Now, health insurance coverage is important. We've been fighting to protect the Affordable Care Act and other programs that provide coverage, but this goes beyond just coverage. This is actual access we're talking about and affordability. So we know that there's a range of drivers that are behind this. I'm not going to go through those today, but we'll certainly touch on them in the discussion. But the point is, there's no one single driver, there's no one single solution. So with that, I hope I've set up the morning, and it's back to you, Dr. Osborne.
Thank you. Well, my goal is to really set the stage for the next three speakers. And although we certainly know that once someone is sick, that there are a lot of things that their lifestyle does to either perpetuate or to help to alleviate their illness. But we also know from a lot of the science today that what is happening to us in our earliest years really is highly predictive of our health and well-being later in life, of both our morbidity and our mortality. And we know what is going on with our children today, which really sets the stage or helps us to understand what the needs of those kids are going to be in 10, 20, and 30 years from now. And our healthcare system has to figure out how it's going to either respond to that or how it's going to work to try to prevent some of the effects of early adversity. So Mark Hayward is going to spend a lot of time talking with you about the science behind how our bodies really don't forget. And I'm going to kind of set the broad stage for that. Georges Benjamin, who is the executive director of the American Public Health Association, is going to talk a lot about the disparities in our health and well-being among our children and about some of the prevention efforts. And Tricia Brooks from the Center for Children and Families at the University, I don't have on my glasses, so I'm sorry. I thought I could just wing it, but I can't. The Georgetown University McCourt School of Public Policy is going to talk a lot about how our children are cared for now and some of the disparities in their care. But we really have a great understanding through brain science today that our earliest life experiences have lifelong consequences. And I want to demonstrate to you what the prevalence of some of those experiences are among our littlest ones and all of our children, and that they differ quite a bit by some of our most disadvantaged groups. It's also, as John mentioned, the demographics are changing, and our populations that are growing the fastest are those that are the most disadvantaged. And so that means that as we understand how our early adversity predicts the future, that that's the population that's experiencing the most adversity is the population that's growing the fastest. We can do something to prevent this. We can offset many of the effects of early adversity, but we have to start very, very early, and we have to stay with these families and support them. Many of you are probably aware of a study called the Adverse Childhood Experiences Study. This was a study that took place in the late 1990s. It was mostly an advantaged population of mostly white college-educated folks who lived in California and were all covered in healthcare with Kaiser Permanente. And they did a look-back study, and they asked them about some of the experiences that they had as a child before they reached age 18. And what they found is that one, most of these folks that they studied, and there was about 17,000 of them, had experienced some adversity as a child, and that it had what we call a dose-response relationship with their health and their morbidity in their 60s and 70s when they were being surveyed, meaning that for each additional adversity they had, it increased their risk of negative outcomes. They asked about 10 specific types of abuse or adversity in their childhood, both 3 different types of abuse, so physical, emotional, and sexual abuse, extreme neglect, both physical or emotional neglect, and what they refer to as household dysfunction. Whether your parents suffered from severe depression or mental illness, whether one of your parents or relatives were incarcerated, whether you lived with someone who was substance abusing or abusing substances, whether your parents divorced, whether you were whether your mother was a victim of domestic violence. There are a lot of other types of adversity that we could check off the list, but these were the ones that were in the original study. And what they found was that nearly 2/3 have at least one, reported they had at least one of these early adversities, and nearly half reported 2 or more. I know that this graph here is a little bit too hard to see, but this demonstrates what the prevalence is of these levels, what the prevalence of adversity was among these participants. And so 28% had been physically abused. Nearly 15% had been emotionally neglected, and 27% reported that a member of their household had a substance abuse problem. And again, what the findings were pretty clear, no matter what it is that they were looking at, and again, Dr. Hayward will go into much greater detail, that they found that the greater the number of risks that you are exposed to, the higher your level of risk in morbidity. And they looked at all sorts of things. They looked at these behaviors that we're talking about being sedentary, about abusing drugs or alcohol, about smoking and other sorts of things that lead to negative health outcomes. But these behaviors were linked to their early adversity. We can predict the kind of probability of those behaviors by your early adversity. And then they looked at all sorts of different types of physical and mental health and found that that stair-step relationship, that dose response, was prevalent in almost all of them. And what happens, and I don't have time to go through all of the brain science and other sorts of important science that has been done in this area, but that, and Mark is going to be able to tell you a lot more about this, but that early adversity really does get under our skin. It affects both our physiologic response, it affects our neurologic development, and it even affects the expressions of our genes. And that these have lifelong consequences that lead to early morbidity as well as early death. They actually found that for those who reported 6 or more ACEs, or adverse childhood experiences, that their life expectancy was 20 years fewer than those who reported 0. We've updated this to look at the prevalence among children today in our National Survey of Children's Health. And this is a large study. It's been conducted twice now. And we're seeing that about 20% of our kids have experienced 2 or more of these adversities in their life, and that it's much more common among kids who are a race and ethnic minority or who live in low-income households. This is kind of the prevalence across the country in terms of where our highest rates of risk are or not. And the darker blue are those that are significantly lower than average, whereas the lighter blue are those that are higher than the national average. In Texas, it's kind of right at that national average. And this is the proportion, the 46% who have at least 1 ACE, and over 20% of kids who have 2 or more across their childhood. This is the prevalence. I'm not going to go through these, but we will make all the slides available of these different sorts of adversities that they looked at. And we can see that over a quarter of our kids are exposed to extreme economic hardship throughout their childhood, that 20% experience some sort of family disruption, and so forth. And these are the national numbers and Texas numbers, and we also have them for Travis County and Austin, for those who are local, and the numbers are nearly identical. This just demonstrates the difference across race and ethnicity and the level of exposure to adversity early in childhood. And so on your right, the panel there are those children, the percentage of those who had no adverse experiences in their childhood. And the blue bar are for non-Hispanic white children, the orange are non-Hispanic black children, and the gray are Hispanic children. And you can see the differences. On the left-hand panel are those that experienced 3 or more. And there's huge differences between our white and Hispanic children and our African American children who are exposed, more than 15% are exposed to more than 3 adverse experiences. This is the differences by poverty level. So again, on the right hand are those who have no adverse experiences, and you can see that 70% of those in families who are in 200% of the poverty line or greater report no experiences, as compared to just about half of those who live at the poverty line or below. And on the left-hand panel, you can see the stair step related to those who have 3 or more adverse experiences. The following sets of slides, I'm not going to go into a lot of detail with them because of time, but it really demonstrates how disparate our children's lives are based on race and ethnicity, based on their parents' education level, and so forth. So this is the percentage of children who live in poverty by race and ethnicity. About 21 out of 5 of all of our children live below the federal poverty line, but it is much more common for our African American children and our Hispanic children. And in Texas, the rates are just as high. Our rates of child maltreatment differ by race and ethnicity. And this was not in the original study, but they counted divorce as an early adversity. But more than 2 out of 5 of our children are actually born to parents who are not married, most of whom will not be married. And that is true for nearly 3 out of 4 of African American children and more than half of Hispanic children. And so early on, they're in families in which they're going to struggle more to try and provide the resources that they want for the family. So I wanted to just get to the projections of child population so that you can see where our population is headed. These are just projections up through 2020. We have a pretty good sense that these are going to be pretty accurate. And you can see that the white population is declining among children. The African American population is staying pretty stable, but our Hispanic population is growing considerably. And in Texas, this is true for much more true than it is for even the rest of the country. You can see the top blue line that predicts the growth in our Hispanic child population by 2050. So what the next 3 panelists are really going to hit home is the fact that our early experiences do have lifelong consequences, and that the prevalence of adversity is actually pretty high, but it varies so much by our subpopulations, and that's an important thing to pay attention to. But that our population is actually increasing most among those who are most disadvantaged, and that our systems really do need to get on board to recognize how they can play a role in helping to stem this tide. I appreciate if you could join me now in welcoming Dr. Mark Hayward. He is a professor here at the University of Texas at Austin, and he leads our population health initiative. And he has, I always think of my favorite saying from him is that our bodies never forget, and that is something that really sticks with me a lot. So he's, again, please join me in welcoming Dr. Hayward.
Thank you. Is it still on? Okay, good. How do I do slides? Oh, right here, right? Okay, there we go. Cynthia said I would talk a lot about a lot of things. I won't, because I'm a professor, and if I talk a lot about, I'll get the hook. We love to hear ourselves talk, so I will try to talk less. I will try to give you some straightforward examples, but I won't cover the waterfront, because the waterfront is broad. There's a lot of thorny issues, I will allude to some of them, and we have a question and answer period, so I'll kind of leave myself open for a conversation after this. So I once wrote a paper called The Long Arm of Childhood. I've dined out on that paper a number of times. There have been conferences that have been named after that, so I get invited to do keynotes, and I get free dinners and drinks, and so it's been a really good time. Who knew that a title would get, increase my BMI? But anyway, what I want to kind of convey, and this is actually more common now. We think the body doesn't forget, but not too long ago, we weren't so sure. I mean, when I mean not too long ago, when I first started presenting some results about the kind of long-term permanent consequences of adverse health events in childhood, my social science friends said, "Oh, this is ridiculous," right? They just didn't believe those numbers, and I'm talking presentations at Harvard and Wisconsin, so it's not like, I was talking to really smart people, but they did not believe me. And of course, I kept saying evidence, and they kept saying, well, this doesn't fit with their worldview, and it kind of shows the conservatism of social science and science in general. Cynthia set the stage much better than me. I really want to point out, so we think about this now, a quarter of the kids are born in poverty. It's going to get bigger, not smaller, right? It's a snapshot in time. So think about, roll these numbers forward. Cynthia talked a lot about the ACEs. Remember the Kaiser Permanente study? Those were adults reporting on the ACEs. It's not like they're going to over-report the ACEs. They're likely going to under-report the ACEs. And we're already looking at a kind of relatively economically successful sample. So in some sense, when we roll out these numbers from these surveys, they're actually kind of tip of the iceberg numbers. We should be aware of that because we still have heterogeneity and kind of unobserved influences that are coming. And we can't account for them all because they are unobserved. The other thing that we are getting a much better handle on is that not only does childhood kind of get under the skin in ways that are, I would say, both pathophysiological in nature, like it's going to set off an atherosclerosis, inflammation, a variety of things that have to do with maybe metabolic and cardiovascular and neuroendocrine. It also, and these models are much less articulated, but there's increasing evidence that it's influencing cellular aging. And so we have multiple biological mechanisms by which this stuff is happening. Sometimes we throw out our favorite diseases. That's more of a pathophysiological perspective. But cellular aging is also probably playing a role, and we're still kind of wrapping our heads around how all that stuff is working. So I just want to point that out because we're learning things all the time, pretty much on a daily basis. The other part is the social part. The social part often, it's not like, oh, I'm a poor kid, and I live a life as a poor kid. Then I show up in adolescence and someone randomly assigns me to a new family, right? So maybe I can skip into a new family with random assignment, and then I get out of my adolescence and I get randomly assigned into adulthood conditions. Those random assignments don't work, right? It's a great thought experiment. This is how we would learn about what the effects of childhood are, separated from the adolescence, separated from the adult. But we don't do random assignment. The world is not like that. We are not a randomized controlled trial. But we are channeled, right? And I think those channeling processes, we have to be aware of the fact that a lot of what happens in childhood is often reinforced by what goes on in adulthood. And I'm going to kind of give you a sense for what that means in terms of the overall heterogeneity and disparities that we see in the population out there for different kinds of outcomes. So I will skip the ACEs, thank God, thank you. This is a stylized graph that I made up and looks really crappy, but I don't care. It works for me. It's a graph that I have stolen from physiological discussions, and it's all, the physiology people almost got it right, but they should have had a social science consultant to talk to them a little bit. Let me see if I can do the pointer here. So The thick lines here are really what I would call common experiences in the population. So I have, let's say, 4 groups, groups A, B, C, and D. And what I have is 2 groups. These 2 groups share the same line as children. And the other 2 groups share the same line as children. They don't really, but I'm just trying to show you the kind of stylized way. But even at birth, there's already separations in what's going on, physiologically speaking, especially metabolically speaking, and perhaps cognitively as well. Through childhood, we have these inputs in developmental phase of the life course, and we're really talking about I'm talking about gains in capacity. It's really about what happens to the brain? What happens to the basic biological systems? Where are we gaining capacity, and then how do we hold on to capacity? So there's a separation here, of course, because we have fewer inputs in the determinants of gain for those groups. We have more inputs for the determinants of gain for those people. And you can think about them as, here are the advantaged people, and here are the disadvantaged people. Well, what happens to the disadvantaged group? They peak, and they peak earlier, and they peak at a lower level. So just in terms of the building of capacity part, the part that's from childhood and into adolescence, they're not going to go as far and as long in their developmental processes. Now we have the advantaged people. They're cooking, right? I mean, especially if you want to think about, a neurological perspective in terms of brain development. My goodness, they're really cooking. And they get up here and they stop, quote unquote, stop developing later and higher in life, right? But things happen. So here's the common thing. I'm in an advantaged childhood, I have an advantaged adulthood. Social mobility is at an all-time low in the United States since before the Depression, right? We're quite sticky. You grow up in an advantaged home, you are an advantaged child. You grow up in a disadvantaged home, you stay a disadvantaged adult, right? It's very difficult. But we do have people that get off track. So I grew up advantaged, and I became disadvantaged as an adult, and I start to decline in terms of my capacity. Maybe I got lucky. I'm one of these disadvantaged children, but I got lucky. I went to the University of Texas and not Texas A&M, and I really recoup, and I do pretty well, okay? Now we get out here, and you can see, just in terms of some arbitrary threshold out there in life, this is where you cross the line, so to speak, and you say, well, now I'm below some threshold in terms of capacity. Here is the extreme difference, right? So I'm going to give you one more example from some work that we've done. We were actually looking at the years of healthy life and life free of any functional disability problem, right? Free. So we have this, it's not ACEs, but we have a kind of cumulative SES adversity scale that was available in the data set that we were looking at, health and retirement study. And like Cynthia's ACEs discussion, the relationship between our scale and these outcomes is a dose response, right? Except you can have one, because the one is father had a blue collar occupation. That's very common in this group. But any additional adversity, and you have a dose response relationship. We also measure child health in an incredibly crude way, right? Fair, poor, good, very good, and excellent. And finally, we're looking at education because we're actually asking the question, can a good education overcome a poor childhood? Something we should pay attention to. So I won't get too much into this, but we're really looking at, does the effect of childhood continue directly? Does the effects of childhood health continue directly into this healthy life expectancy? Or is it all about education, right? So can we kind of get rid of the effects of what's going on with childhood? Can we get rid of it if we suddenly improve every school district that we have? No. So what I've done here is I've given you a sense for, here's the childhood SES adversities. And here's, if you have if you have less than high school, here are the years of a healthy life at age 50 for people with no adversities, 1, 2, 3, 4, 5. And you can see, starting from here, there's a dose-response relationship that goes on down there. Now, look at what goes on with education. So I start out with, if I have education and I go up with 0 adversity, 7.7, up to 15.3 years, education has a whopping effect, right? It's actually whopping. And now this gives you a sense for how these levels of adversities interact with college and education. And let me just point out one more thing. That's the overall level of heterogeneity in a crude sense in this population group. But here's the bottom line. There's no way that education gets rid of the effects of childhood. Some effects go through. There is a pathway, don't get me wrong. You know, the problem is that our bodies remembered in these analyses, our bodies remembered when we were kids, when we had poor health. Our bodies remembered when we were poor. Those things added to, right, added to what happened in education. Now, you may think this is not a great story. That was poor health, and I'm getting the signal for I'm running out of time here. But let me just point out some important issues. So your body may not forget, but if you can get that kid into a good channel, the kid will remember being in that good channel. So yeah, education matters, right? It actually is an incredibly important policy lever. And there are other policy levers, not just education, but there are other policy levers that we have, because our bodies will remember where we are exposed and when we are exposed to. Yes, if you get those kids into a good education, if you can get them to graduate from high school, if you can get them into college, they're going to benefit. Does it mean that the disadvantages of childhood go away? No. But what they do is they take on the new advantages of where they move to. It's a lot better than if they'd just been stuck in a disadvantaged system their entire lives. So yeah, we can really change people's pathways. We can change their health trajectories. You can't change their body's memories, but you can change their body's futures. Thank you very much.
Thank you, Mark. I really appreciate that, and appreciate you turning the tide a little bit for us at the end so that it didn't feel quite so much like destiny. Now, please join me in welcoming Dr. Georges Benjamin, who is currently the Executive Director of the American Public Health Association. And we're really honored that you're here today to talk with us.
Well, good morning, everyone. I want to try to take this from a systems approach a little bit. And just again, as John pointed out, we don't do as well in terms of health outcomes, despite the enormous amount of money that we spend on health outcomes. And quite recently, the Commonwealth Fund asked the question as to why that is. And in doing so, they basically came up with really 4 reasons why that's the case. First of all, we have a system of health in which not everyone is in it. So we don't have universal health care. And again, just to remind you that we're the only industrialized nation on the planet that does not have a system with everyone in and nobody out. We tend to have an insurance-based system, but that is one of our central challenges. Secondly, we have a very complex system, not just the payment part of it, but also the delivery part of our system is very complex. The third issue, of course, is that we focus so much on the acute care side of the house and not as much on primary care, prevention and wellness. And then fourthly, the issues around the social determinants. We invest far less than the other industrialized nations. If you look at how much we spend on health and social services, we spend an enormous amount of money in the health side of it, and certainly not as much as other industrialized nations on the social service side of things. And then, of course, you know, we always talk about the fact that there is an enormous part of what makes us healthy is outside the doctor's office. So I spent the first half of my career in medicine as an emergency physician practicing clinical medicine. I got to tell you, it pains me to own up to the fact that only about somewhere around 10 to 15% of health care actually determines our health. But it also tells you about the outside of what these social determinants are in many, many ways. And of course, health reform is supposed to help us with that. Actually, the Affordable Care Act, although everyone focused like a laser, and we're fighting very much on the health care coverage parts of it, there were just an amazing number of other components of that law which were designed to go to pay for performance so that we could change the way our expectations were on health. John alluded to some of that earlier. We do a lot of prevention and wellness activity in that law. There were things around workforce that were there that actually never got funded, never got really implemented. But the idea of recognizing that as we're aging, we're moving into a time where we really don't have the workforce to address those of us who are getting sore joints and having to move a little slower. And we had some innovation money in the Public Health and Prevention Fund, which has been tragically tapped for everything else other than public health and prevention. But nonetheless, there was the bill was designed and then signed into law. And there's been some pretty decent outcomes on this law overall. But I want to focus a little bit on trying to make the idea of social determinants and public health in this future world we want to live in real, and talk a bit about how we want to go more and more upstream. Just recognizing that one of the tragedies is that your zip code is a very, very strong surrogate determinant of your health. When people talk about those folks that live on the other side of the railroad tracks, that's exactly what we're talking about. I mean, it's a visual representation of the enormous differences we have in health. You can see it, you can breathe it. Everybody knows exactly what I'm talking about. Those disparities are real. They're designed by our policies. And the fact that we don't fix them has a lot to do with who gets paid to do what. Racism, discrimination, class, a whole range of things that are designed to make sure that that's exactly what happens. I remember when my father died, getting the look at the deed of our house. I grew up in Chicago on the far south side. I probably have only one ace, but maybe two. I grew up in a fairly prosperous middle-class home, but I remember turning the deed over and the language which basically said that they were not allowed to sell our home to African Americans. You know, those things are real. And so this is not something that we don't know about. All of us know about it. It's one of the dirty little secrets which now we're looking at it. And there are lots of ways to measure this stuff. And we're beginning to see some of that being measured today. But also it tells us when you have to see about all these things across sectors that we have to do to try to improve our health. It's clear that if we're going to do this, we're going to have to do this in a multi-sectorial way, with lots of people involved, with health as the outcome. But we're going to have to bring lots of other people to the table. It's not just about what physicians and nurses and nurse practitioners and physician's assistants and others do, nutritionists, et cetera, to make this stuff happen. We've got to do something that's quite differently. So let me just tell you a little story. So, you know, asthma, which is a very common clinical condition, affects lots of kids, disproportionately affects kids who are in underserved communities and minorities, is something that we see a lot of. And so as you're thinking about dealing with a kid with asthma, understand that it's very, very important to understand the clinical nature of that child, why this kid is having a poor clinical outcome. And quite often it's the usual stuff. You know, they can't afford the medication, or they don't use the medication correctly, or they have some things at home that impact and cause triggers for their asthma. But if you really understand both the clinical aspect of this child's condition and the social determinants around that child's condition, you can make solutions that really address both. So I'm going to give you an epidemic, and I'm going to define this epidemic on a particular day of the week, 4 particular healthcare systems, 4 different hospitals. And each one of these hospitals is seeing a very, very small number of kids on the same day. But the numbers are small enough that nobody would have picked it up. You know, there's a kid here and another kid there, but they're very different. But, you know, if these were cases of measles, and you had 10 measles cases that walked into 4 different hospital emergency departments, we would know exactly what to do. We would track these down, and we would have an epidemiologist all over this, and if it was Ebola, we would go through the roof. So let's say that this happens on a particular day, and note that each one of those kids, or clusters of kids that goes into the emergency department have, you know, they're different, they're individuals, but they all have different characteristics. So the health department gets notified. We devise a system where we actually notify, just like we would for measles. There are kids in the emergency department that have asthma. The health department gets notified through a variety of ways. The emergency department can notify them because we have a sophisticated electronic medical record system which notifies kids, the health department, when kids have asthma and show up in the hospital emergency department with uncontrolled asthma. Or because the school, which of course does school absenteeism every day, notifies the health department that they had kids out of school that day with asthma attacks. And they can crosswalk that. As frankly, it's a great way to verify that those kids were actually happening. And the important thing is that these kids, one common denominator, the kids, of course, all went to the same school. There was a variance in where they lived as the health department got into this and tried to figure out what was going on with those kids. But the big deal was, of course, they were all gone out of school on the same day. And again, just to remind you, no one would have picked this up because, again, these numbers are so small that they would have not made a dent in anyone's concern. They looked at insurance carriers, they looked at the utilization in the past of healthcare services, and at the end of the day, there was only one common denominator, which the health department was able to figure out that caused these kids to have asthma problems. And that was all because they all rode the same school bus. And the school bus had a broken tailpipe. Broken tailpipe, knocked its fumes, asthma exacerbations. And so, you know, this is an important determinant. And you think about who's now all involved in this, and multiple systems involved, the school, the transportation system, the health department, the hospital system. And of course, there's a hero. Every great story has a hero. And this is the hero, the bus mechanic, who fixes the tailpipe. And of course, if they do this right, the bus mechanic then goes and checks all of the other tailpipes on the school system, and of course fixes all the other problems they find as well. And now you have a system which is providing coordinated community care across your system. It involves, again, the school system, the hospital system, the public health system, the transportation system. If this is done right, you can dramatically reduce healthcare costs, reduce emergency department visits, improve healthcare quality. Because of the population you're looking at, you're going to address disproportionate care in that population. And a marvelous system. And by the way, we can do this today. We have the technology to do this today. We have all kinds of barriers, some real and some artificial. People make up rules when they don't want to share data. And we can do this today. And I think at the end of the day, that the most important thing is for us to address a system which really wants to look at health holistically. We can do this for pretty much every one of those issues around children, around adverse experiences, because those of us who have been in the human services world know that the population that has those multiple terrible experiences, it's all the same population. Sometimes social worker A is handling them off to social worker B, who's handing them off to the WIC worker, who's handing them off to the health department person. They often come into the same building on multiple days for multiple services. And we have just failed them to put those systems together to really address their needs on an early care basis. Thank you very much.
Our last speaker on this group of panelists is Tricia Brooks, who is a senior fellow at the Center for Children and Families at the McCourt School at Georgetown. And we're really glad that she's an expert on children's health insurance, and we're really glad that you're able to come and share with us this morning.
Thank you. So I really want to focus on the role that Medicaid can play in addressing a lot of the thoughts that have been put out there. Let's get into this. So first of all, we can celebrate the fact that over 95% of children in America now have health coverage. We've been on an upward trend for the past 2 decades, since the Children's Health Insurance Program was enacted in 1997. But you can see there are disparities among states. In Texas, a child is twice as likely to be uninsured than the national average. And the reality is that Medicaid and CHIP are largely responsible for these gains. We have known for many years, I've been working on children's health coverage for over 2 decades, but we've known that there was always a large number of children, somewhere between 2/3 and 3/4 of uninsured children were eligible but not enrolled in Medicaid and CHIP. So we've done a better job. This particular slide shows you how we've seen increased participation of eligible children in Medicaid and CHIP, and that's what's driven those historic highs of coverage. Medicaid is the single largest coverage source for children. Now we know, or it's the largest insurer, we know that more kids get their coverage through employer-based coverage, but those are different insurers, different types of coverage. Medicaid is the single largest source of health insurance in this country for kids. More importantly to the topic at hand is that Medicaid covers our nation's most vulnerable children. 4 out of 5 children living in or near poverty rely on Medicaid for access to health care. Our youngest children, in those key brain developmental years under the age of 3, nearly half of our kids are enrolled in Medicaid. Almost half, 40%, of children with special health care needs or disabilities rely on Medicaid. All of our children who have suffered those adverse experiences because of abuse and neglect have been removed from their homes are covered in Medicaid. And then at least half of our births, the pregnancy and births of children, are covered by Medicaid. So you can see that Medicaid has a critical role to play as we address what the trajectory for children's health is going to be in the future. And I would also say that Medicaid is the only system that we have to connect to all young children. Not all young children are in childcare. Not all young children are in school. So Medicaid really offers that entry point, that point at which we can connect with these children and families. There is ample evidence that Medicaid does contribute to children's success in life and in school. They miss fewer school days, they do better in school, they're more likely to graduate from high school and attend college, they grow up to be healthier as adults, and because they've had better education, they earn higher earnings and they pay more in taxes. Medicaid also strengthens families, and this is even more significant since the Affordable Care Act was enacted, and that is by expanding Medicaid to low-income parents. We know if parents are healthier, they're going to be more nurturing parents. They're going to be better parents. They can get out of bed. They can go outside and play with their kids. Medicaid also contributes to family economic security, which is, again, another big driver of how well kids do. And then Medicaid and having coverage reduces family stress. It gives families peace of mind. These are all things that impact the success of kids. But as much as I am a coverage advocate, it's not enough, and we know that. There's more and more evidence that is pointing to our need to address those root causes of health that are far beyond medical care, and we've certainly touched on that a lot today. So I really want to focus more on this leadership opportunity that is in front of us in terms of Medicaid's role. There was a very good blog in Health Affairs back in September by Catherine Whitgert, where she talks about the central role that Medicaid plays now in providing health care for millions of Americans, particularly the lowest income Americans, and how that is an ideal platform on which to build an integrated system that addresses both social needs and health care. My colleague Kelly Whitener and I recently produced a white paper on the social determinants of health. I always like to give the disclaimer, my PhD candidate's son, who's studying public health at Washington University at St. Louis, tells me I am not a researcher. I write white papers, and that is true. I think what we try to do at the Center for Children and Families is translate some of this technical information that we get from research and advance it as actionable policies at the public policy level so that we can give kids a brighter future. Some of the ways that, and we would invite you to take a look at our paper, it talks about the different things that Medicaid is doing, can do, to address the social determinants of health. Just by states adopting optional benefits like care coordination and targeted care coordination. Working more on some of the things the Commissioner talked about this morning of value-based purchasing and incentivizing those newer models of care. Helping with data collection and measurement, which is a key piece. The Commissioner talked about really focusing on quality. Well, you can't focus on quality if you're not measuring it. Looking at beyond just the delivery of care, things like multi-benefit applications. So when a family applies for Medicaid, they're also applying for food assistance. Having those integrated eligibility systems so that families can get that determination for other social supports at the same time they're getting their health coverage. And even something as simple as adopting Bright Futures, which is the American Academy of Pediatrics recommended schedule of screenings and preventive guidelines, which the new iteration talks about screening for the social determinants of health, screening for poverty. But we know that screening's not enough because then we have to make those connections to the services. So I would invite you to take a look at that paper and some of the things that Medicaid is doing. And more importantly, there is work that's being done at the federal level to to figure out what the role that Medicaid should play. Most recently, the National Quality Forum convened an expert panel with the Centers for Medicaid and Medicare, and they released a report in December of 2017, which again is also worth the read if you're interested in digging in more into this topic. So the first recommendation they came up with is that we need to acknowledge that Medicaid has a role in addressing the social determinants of health. And then something that seems quite simple, but is harder to do and certainly doesn't get distributed well, is just to have a comprehensive list of what are the community resources that families can depend on? How can healthcare providers help get those families to those additional resources? How do we harmonize some of the tools that we're using to address the social, or to assess the social determinants of health? Can we create standardized measurement tools so that we can get the data that we need? Can we standardize our electronic health records so that we are collecting that data? And can we promote exchanging that data among multiple government agencies? These are all things that will contribute, in addition to looking at those newer models of care and that value-based purchasing. This report also suggests a framework where Medicaid or healthcare entities serve as a hub for accessing the additional social supports that people need that are spokes in that hub. And so, again, I would invite you to read that report. I think it's well worth the read. So I want to talk just a little bit about a couple examples, and there in our paper we have a list of resources that point to some of the more technical publications on what's happening at the state level in Medicaid to address the social determinants of health. But in Kansas, for example, they have quality strategy that includes measurement for reporting and paying for performance on targeting members who have severe mental illness or substance use disorders or developmental disabilities in terms of their health risk assessments and what can be done to connect them with additional services. In Oregon, they've long been, they were sort of the leader in accountable care organizations, where they're care coordinating entities at the regional level, and they very closely align Medicaid and early childhood staff so that there's that integration, so that when a child is screened and needs services, that they can get into those early childhood services and have those needs addressed. And one of my favorites, which is more recent, is in Massachusetts. They've actually developed a neighborhood stress test. They're looking at zip code. In New Orleans, in certain zip codes, you'll live 25 years less than you will if you live 2 miles down the road. It's such a predictor or a good proxy for it. But they look at your income, at education, at transportation, at unemployment, at other factors, and they've come up with this neighborhood stress ratio. And for each increment that particular neighborhood has, then the providers actually get an incentive payment. And in high-stress neighborhoods, where a provider might have a panel of 2,000 to 3,000 individuals in this particular neighborhood or nearby neighborhoods, they can get $100,000 a year, which helps them pay to have social workers on site to help connect families with services. So these are some of the things that are going on in Medicaid, and there are a lot more examples. But here's my concern. So most of the work that's going on in Medicaid is actually, there is a pointer here, but I'm not sure where it is. All right, I'm not going to bother. But the bars on your left, you can see the elderly and disabled are our highest cost populations in Medicaid. And that is where we are spending the bulk of our focus in our innovative care models in trying to address high cost. And so one of the soapboxes I always have, and I see this in quality measurement for kids as well, is that we're not focusing on kids because they don't cost a whole lot of money. And yet, if we're ever going to change that trajectory, we've got to start when they're kids. And you know, this is happening even though half of the people served in Medicaid in this country are children. In Texas, that number's 75%. And yet we are still focusing on the high needs populations. And of course, there are some kids with complex health care needs that are being addressed in those models, but it's not across the board. Now, here's another concern, is that we don't seem to think that we should be investing in Medicaid and health care. There have been numerous efforts in the past year to cut or cap Medicaid, and I could spend the next hour talking about those, and I'm not going to go into any great detail, but just to make the point that if we cap or cut Medicaid in the future, it's definitely going to impact and undermine the efforts, those emerging efforts that we are now embarked on in terms of changing that trajectory. And it's not just Congress that was doing that. The president's budget actually proposes deeper cuts to Medicaid than any of the proposals that were rejected in Congress this year. And not only that, but also wants to cut food assistance by 30%, wants to cut housing support by 15%. And that's just going to make the problem worse, not better. You've already heard, we know the U.S. spends more money on health care, 25% of the next highest nation, 50% more than the average of industrialized nations. But I would invite you to take a look at a book that I thought I had it here in front of me, but I don't have it. So it's called The American Healthcare Paradox: Why Spending More is Getting Less. And it really takes a look at how we spend on health, but also what we spend on social programs. And this was mentioned earlier, that 13%, we rank 13th in the nation, in the world, in terms of our spending on combined health and social programs. And that is what is making a considerable difference in our not achieving the health outcomes that we should achieve in this country. Whoops, one more slide before we get there. If we continue to look at cutting Medicaid, here's what's going to happen. We're not going to see states boosting money, boosting the state spending on health care. We're going to see them closing and cutting enrollment, imposing more red tape barriers. We already see this happening at the state level in Alabama. And I know there are people who have different opinions about this, but in Alabama, they're proposing work requirements for Medicaid parents. Medicaid parents in Alabama are eligible only to 13% of the poverty level. They earn $321 a month. And yet, if they meet their work requirement, they will lose their Medicaid because they'll earn more money than Medicaid. And they're not likely to be employed in jobs that are going to give them health care. So there are lots of things that could happen that would not be very bad, not be very good. I'm sorry, I'm rushing here. So let's talk about my key takeaways, and that is that investments in Medicaid and other basic needs are really critical to children's futures. We know that Medicaid serves the low-income kids. These are the ones that are most impacted by the social determinants of health, and therefore Medicaid is a logical platform for addressing health care and social needs, but cuts to these programs will undermine our emerging efforts. To be successful, states really need a stable funding source, a trusted partner in the federal government. And even if we're able to preserve Medicaid and make progress in addressing the social determinants of health, health stakeholders and child advocates will need to fight for priorities that have a longer-term return on investment if we're to reverse these trends of poor health status, obesity, and chronic disease that gain their foothold in childhood. Thank you.
Thank you. I'd like to invite our panelists to come and join me in the chairs up here, if you would, so that we can have more of a conversation. We have time to open it up for questions as well. I believe that there are a couple of folks with mics. Could you tell me where you are? Oh, it's going to be you too. Okay. This is our person with the mic. Sorry, Tricia. And what we definitely would like to have a conversation and to have you asking questions. So I might start us off just a little bit, but please raise your hand, stand and let us know who you are. And yep, perfect. Okay. All right. And I'm going to give the mic to you, and I'll use. Let's see. This is my, you can hear me here. Good. Make sure that we get all.
Yeah, it's not going to go on. Anybody have batteries?
Let's see. I'm not sure what's going on. Yeah.
Yeah.
Maybe you two can share yours for a second while they replace those batteries, because I think it's being recorded. So even if you can hear me, then it would lose out for on the recording. So I do appreciate all that you guys shared with us, even though it's not all positive, but it is somewhat encouraging that there are strategies that we can actually use. Mark, I'm going to put you on the spot a minute. You talked about education as one of the mediating pathways that we might help to offset some of the early adversity that our bodies are exposed to that will affect us over the long term. I know from research in early childhood how important a close attachment and loving relationship is with at least one adult, and how that can help to offset some early adversity and what often people refer to as toxic stress. Can you talk about any other pathways that have been measured that, especially those that might affect policy, that if we were to invest in those, it might help to offset some of the early adversity? Let's definitely try to offset that directly too, but indirectly. Do you know of other potential pathways?
So part of it's direct and part of it's indirect. So a lot of the kind of relationship issues that you were raising in terms of stability of relationships within families as when kids are kids, those are direct consequences. Those are the kind of stress, the perspective that gets into the at that point is a very much of a direct effect. Now, so you can do all sorts of things in terms of policies for families. And I think it's things like ITC, the best, most effective anti-poverty program that we have out there. And we have the federal level, but with this, half of the states have EITCs. They vary in generosity. They vary in terms of when they were staged in. But so we have a lot of kind of policy ways of going after this. I was really, it was refreshing to hear the other speakers because the policy, those upstream factors are so critical. And we have a couple papers. One was just coming out in AJPH, but it was where in the United States, across the states, do we see, big disparities in health outcomes and small disparities in health outcome? And basically, across every state, if you're well educated, we all look alike. Right? We all do well. But for the disadvantaged population, for the less educated group, it is like a ski slope, right? The inequalities are huge out here in states that don't invest in their populations. I mean, states invest in a variety of ways, and it really is a variety of ways. Just to give you a historical context, we had this thing called the Federal Devolution of Power, which basically turned over the responsibilities of many social welfare programs. Gradually, more and more autonomy goes back to the states. It used to be in the United States that the inequality between states in life expectancy was actually relatively small. The state differences now in life expectancy at birth for women are 7.4 years between the highest and lowest states. Just to put this in perspective, it happened fast. It happened over a period in which we saw massive changes in public policy going from federal levels to things like block grants back to the states. What's a state do with a block grant? Sometimes you don't know what to do with a block grant. Sometimes you don't spend the money with a block grant. States have different regulations, different ways of enforcing. So the variability that happened a lot with federal government turning responsibilities of social programs back to the states is having a big effect. You got me started. I have a new NIH grant on this, so I'm totally, this is a problem.
We're going to hold a conference on this issue.
This is a problem.
In and of itself. And Georges, for you, I really appreciated the idea of taking this public health approach to even what are these very chronic and common problems, such as asthma. I thought that this example of the difference between the way we respond to measles and asthma was just very, very poignant. This idea of the systems talking to one another is something that I know here in Austin folks are trying to work on. I know communities across the country are really trying. In your opinion, what are some of the first steps? Who are the systems that are the most important to come to begin these conversations with, especially if we're thinking about early childhood and the social determinants of health?
Yeah, particularly for early childhood is health education and the human services, and clearly starting with those children within the care of the state, to which the state touches those children every day is probably the easiest thing to do. I think the one thing you want to do is you want to do two things. One, go to your lawyers and tell them what you want to achieve, not ask them if you can do it. Because if you ask if you can do it, they'll tell you no. And they'll quote all kinds of statutes that do not say what they say they say. Okay?
You're talking about FERPA and HIPAA,
Yeah, well,
sorts of things.
all kinds of reasons. HIPAA was designed, interestingly enough, about HIPAA, which is one of the great mysteries of HIPAA. We very specifically carved out public health so that it would not be a barrier. And then we now have every health system in the world using HIPAA as an excuse to not give data to the health department. We have people in social services departments who believe you can't share data. And the fact is you can absolutely share that data. Now, you don't always have to share a de-identified data.
Right.
Identified data. You can share patterns. There's a whole lot of things one can do. And so there are ways for us to do that. And if you don't think that you can make decisions and get data rapidly, I take you to any grocery store in the country which measures its inventory on a day-by-day, hour-by-hour basis. They know exactly what's going in the store, exactly what's going out the store. And if you don't believe the grocery store, pick up your iPhone and look at your Amazon. We know exactly how to track, patterns in people, et cetera. So we can do it.
Yep.
And we just have to do it in a way that protects confidentiality.
Right. I appreciate that. Absolutely. I also just wanted a question for you. I appreciated the examples that you gave of the different states that are using Medicaid dollars in more creative ways. What are the limits? If you could just help to clarify for us, what are the what's allowed and what is not allowed in terms of how we can address the social determinants of health with Medicaid? I thought that the chart that you showed of the difference in the amount that we spend on adults and disabled versus children was just so telling. And if we know that everything that's happening in early childhood is actually one of the primary reasons why we're seeing such high costs in adulthood, what is allowed that we could, if we had additional money, spend in early childhood through our Medicaid dollars?
So Medicaid has a lot of flexibility, and just even in terms of the optional benefits that you pick up. And for kids in particular, we have the EPSDT, early and periodic screening, diagnosis, and treatment services, which basically say that anything that's medically necessary a child gets, regardless of whether the state plan has adopted that. But there's a lot of room in managed care. In managed care, capitated payments. I know I'd heard a story in Texas about managed care trying to find people who are homeless in order to conduct health assessments and paying a finder's fee to some of the homeless service providers to help them connect with those people. So there's a ton of flexibility, and then there's even more flexibility through waivers where you go and ask the federal government to do things that you normally would not be able to do because of the law. But that said, we can't start paying for housing, with Medicaid dollars. So there definitely are limits, and that's where it's so important for us to have good, strong coordination between other service supports and the Medicaid program. And that, I think you can with care coordination and making the case that this impacts health and healthcare costs. Doing that care coordination to those services is absolutely allowable.
That's great, thank you. I want to make sure to give time to the audience here to be able to ask questions. I, of course, have lots of questions that I would ask all day. But you guys came, and I know that many of you are experts. We might have a question over here, and if you don't mind standing and just telling us who you are.
Hi there. I'm Pat Aronin. I'm a retired pediatric neurosurgeon, so I spend a lot of time taking care of kids with Medicaid. I'm curious, Ms. Brooks, what you said, 80% of kids are covered by Medicaid. Then how do you have the data that, or who are the 20% that don't have it, that qualify for it? And how do you know that there is this tremendous improvement being on Medicaid in terms of how those kids end up doing? I mean, how do you know the outcomes are so much better for them? Where's the data coming from for that?
Yeah, so I think we've not done as great a job thus far in healthcare in general in terms of measuring the quality. How do we know? So let me just address first the eligible but not enrolled children. We make it difficult for families to apply for coverage and keep their coverage. We make them jump through hoops. The Affordable Care Act made a lot of changes there, but families move frequently, and the mail doesn't always follow them. They don't know their child fell off the program until they show up at the doctor, and the doctor says, you don't have coverage anymore, So there's definitely a whole body of evidence out there of best practices. Louisiana is a great state to look at in terms of making sure that kids retain coverage, and you have to put some effort into it. On the quality side, at least in terms of the initial health outcomes, we really put our toe in the water in a bigger way with the Children's Health Insurance Program reauthorization in 2009 by developing the Child Core set of quality measures. But the federal government allows the states to voluntarily report those measures, doesn't require them to report it, doesn't set benchmarks for achieving higher quality. And so we need to invest more in that. Now, actually, the latest refunding of the Children's Health Insurance Program does mandate reporting on the Child Core set, but not until 2024. In terms of that longer term evidence that we talk about in terms of kids being in school, staying in school, getting better educated, there's the whole body of empirical evidence that has been researched over the past 10 or 15 years. And we have a report called Medicaid is a Smart Investment. And in that report you can find lots of citations on that research.
I think we had a question over here. This is a very difficult room to move around in, so.
Hi, Hi, my name's Julia Von Alexander. I'm with the Department of State Health Services. So I'm really interested in this idea of cross-system coordination. I wanted to get y'all's thoughts a little bit more on who should be the convener there and what types of performance metrics and outcomes should we be expecting. These things seem to be on a little bit of a larger time frame, and this state tends to look at a 2-year time frame. So just love some thoughts on that.
Let me chunk it down a little bit, because I think that sometimes we try to approach it from, we've got to transform the system tomorrow, and it's hard to get your arms around that. Where do you start? And one place I think that we should be focusing more of our efforts is on making sure that every child that has an encounter with their pediatrician gets a developmental screening, an age-appropriate developmental screening, and that it doesn't stop there. That's just the first step. So once they have that screening, if there are needs that are identified, if they need further diagnosis, and then that diagnosis supports that they need treatment services or other social supports, we need to make those connections. I think you probably have good models in community health centers where there are social workers often embedded within the practices that can help make those connections. But it's also about making sure that the family has transportation to get to the additional service, and that when they get that service, that the pediatrician knows that there's been that follow through. And we don't yet have those good care coordination data systems. I mean, for a country that has done so much on the technology side, oh boy, are we lacking on healthcare in terms of how we're using technology. And so we've got to do more about that. And I really think that we need to incentivize local projects to really test different models and see what works, and then spread those best practices.
Yeah, there's it's obviously a leadership exercise to start with. I mean, it doesn't matter who starts it, governor, mayor, pick a cabinet official, picking up the phone and calling the other cabinet official and saying, I've got this problem, can you help me with it? And literally sitting down and deciding when they want to do something about it. It's everybody in government has a lot on their plate. But it turns out when you pull 2 or 3 cabinet officials together and decide to work on something, it turns out it saves everybody a lot of money and time and effort crafting a system that works. And these problems hit us in the face each and every day. Our bosses pick up the phone and call us and say, I want you to help me with the problem because, we just had issues, for example, homelessness. And the governor decides, I'm going to deal with homelessness. Well, that's an opportunity because the solution to homelessness is a house. It's also the solution to health care for people who are homeless, because the most important determinant, as you may know, of good health care and achieving good health care is a regular source, is a house, because that gives you a regular source of care. You can link them with a provider. So it's really a leadership exercise, and someone just needs to decide they want to fix it and pull people together and do it.
So I've been given the red time sign because we do have a packed second half of this morning in which we're going to have what we're calling our leadership panel, but folks who are in positions in which they're having to make decisions about how to provide this care and fund this these sort of strategies. And we're really excited to hear from them and to have you engage in that conversation as well. And then we'll finish out the day with the Dean of the Medical School, Dr. Clay Johnson, who will come and tell us more about how we're trying to train our physicians and healthcare providers to think differently about these problems.